Good afternoon. It's a pleasure to be here. Just over 2 years ago today, someone brought this headline to my attention. The Nunatsiaq, an online newspaper from Nunavut, the largest and northernmost territory of Canada, reported on the suicide of a child in a small community. The headline read, "Nunavut has suffered more than 50 child suicides since 1999. In Nunavut, suicides among children under the age of 15 make up 11% of the total suicides, compared to 1% in the rest of Canada." This past spring, the Centers for Disease Control and Prevention in the United States released data over the past 15 years on suicide, showing an increasing upward trend in the United States. Notably, deaths due to homicide have decreased significantly. There are, on average, 13 suicide deaths per 100,000 in the US. The rate is higher in Alaska at 22 per 100,000, and highest among young Alaska Native boys and men between the ages of 10 and 24 at 107 per 100,000. But suicide is a global problem. It is the second leading killer of people aged 15 to 29 everywhere. And the rates vary substantially between countries and within countries. In this image, you can see that the deep red and the dark amber color, if I can, these colors, represent the highest rates of suicide in countries around the world. And you can see the same kind of regional variation across the Arctic, with higher rates occurring largely among indigenous groups in the north, particularly in North America, Greenland, and Russia, as evidenced by the red, which is North America, the green, which is Greenland, and the blue, which is Russia and its regions. The yellow represents the Nordic countries. And I guess this is somewhat easier to track in those countries that collect this data by ethnicity. But clearly, this is a major mental health disparity, a major health disparity. So what causes suicide? My colleague who just spoke previously explained the complexity of this, and it is a complex phenomenon. And it's invariably related to context. Some suicides occur impulsively in moments of crisis, and in these kinds of circumstances, ready access to the means of suicide, whether that's a pesticide, a firearm, or a rope, can determine whether a person lives or dies. Other risk factors for suicide include a breakdown in the ability to deal with acute or chronic life stressors, such as financial problems. And in addition, cases of gender-based violence, child abuse are strongly associated with suicidal behavior. And suicide rates, as I've mentioned before, vary within countries, with higher rates often among those who are minorities or who experience discrimination. And if you look at these three reasons at the top, which are rapid changes in social structure or values, economic turmoil, or social isolation, these are examples of risk factors that are often common across remote Arctic communities. A majority of suicides are linked to mental illnesses, and I want to remind you that child and adolescent mental health problems are largely neglected in the wider realm of public health. And this lack of attention has implications for young people's health and their longevity. As a group, mental disorders are the leading causes of disability worldwide, and they are disabling disorders of youth, conferring the greatest burden of disease on people aged 15 to 49. And 50% of these disorders begin by adolescence. 75% of them begin by the age of 24. The red swath in this graph represents mental and behavioral conditions, and the x-axis shows age, starting at birth all the way to 80. And you can see that's hitting the relatively young ages there. So what can we do? The Arctic Council has proven to be one place where circumpolar cooperation on suicide prevention is possible. Denmark and Greenland brought attention to this issue in 2009. Under the Canadian chairman's work, the Sustainable Development Working Group sponsored a project on mental health issues. And during that chairmanship, research groups mapped interventions for mental wellness and suicide prevention across the Arctic in indigenous communities. And they found a few things. First, that solutions need to be culturally grounded, community-based, and community-driven. They noted the importance of intervention specificity for communities, the importance of culturally appropriate shared interventions across communities as well, things like mental health services or intersectoral cooperation. They also reminded us that studies need to be solution-focused as opposed to problem-focused, that communities, clinicians, governments, and others need to know what works, however, in order to know how to implement the things that work more widely. And they also found that few of the examples of interventions had actually been studied rigorously with rigorous evaluation. When the US assumed the chairmanship of the Arctic Council, we proposed a project to the Sustainable Development Working Group, wanting to build on the Canadian activities, taking into account the elevated risk of suicide in remote Arctic communities, but also recognizing the considerable variation. And I think this is something that we can learn from. The Arctic, of course, is characterized by cultural diversity, small populations, geographic isolation, and standard research approaches to evaluating effectiveness of interventions are challenging in these kinds of settings. So we asked the question, can we paddle in the same direction, as one of our colleagues said, meaning can we actually harmonize outcomes for better communication, evaluation, and translation of the effects of prevention interventions? So we launched the initiative Rising Sun, which stands for Reducing the Incidence of Suicide in Indigenous Groups, Strengths United Through Networks. And the goal is to build consensus around outcome measures that can be used to evaluate the effectiveness of suicide prevention programs across the Arctic. And our product will be a toolkit for selection of agreed-upon intervention outcomes that can be used to harmonize evaluation across sites, enable communities to measure what's relevant to their needs, to share and compare data across studies of effectiveness. And our partners in this effort are Norway, the Kingdom of Denmark, Canada, and the Inuit Circumpolar Council. So we recognize the need for a holistic perspective on interventions, meaning that there might be many different levels of intervention outcomes, because in order to prevent suicide, there need to be policy interventions. There will need to be some interventions at the level of the health system, some will be clinic-based, others will be at the level of the community, and some at the level of the individual. And the goal is to look at all of these as they're relevant. So the process involves 3 major efforts. The first are a series of face-to-face workshop discussions. We started in Alaska, in Anchorage, last year. The second one was in Tromsø in May of 2016. And the last one will be in Canada in early 2017. And the goal of these was to bring forward local communities and have local stakeholders have the opportunity to engage in discussion about suicide risk and the local issues of suicide in those settings. The second major activity is a Delphi process, and that's a consensus-building process that gathers a group of stakeholders. We asked a single question, and through an iterative process, this group comes to consensus. In this case, the consensus is around what are the most important outcomes for suicide prevention interventions, besides reduced suicides, of course. And our goal will then be to figure out what are the best measures to use in order to clearly account for those outcomes. We've completed rounds 1 and 2 of this iterative process. We're in the midst of round 3 and hope to have results soon. The third effort has been around focus group discussions. For those people who are not involved in this virtual Delphi process, which has happened via email communication, Canada and the US are engaging local communities in discussions about suicide prevention and what's most important to those communities as a source of information to complement this international Delphi process. Our last step will be to synthesize this information, to disseminate it, and then to work, hopefully, as a cooperative community on how to implement it. This is just an example. This is the Delphi question that we posed to the stakeholders who are participating in this around the Arctic. And that's included both researchers, clinicians, suicide survivors, representatives of indigenous communities, community leaders. All of these kinds of people are weighing in on this question. So the question is, in addition to suicide deaths, what are the most important outcomes that suicide prevention intervention should achieve in Arctic communities? I want to end with this slide, which essentially shows us the arc of the life course and reminds us that from conception to old age, we're exposed to forces that protect our mental capital, meaning our cognitive abilities, our mental health, our risk for mental illness, our life chances. And we're exposed to risks as well that can threaten mental capital. Our communities are our mental wealth, and I think this is perhaps the most valuable resource of the Arctic, and so it merits priority to address it and to protect and to promote the mental health of communities. Thank you. This is the Rising Sun website. This is the Rising Sun website, which you can find at the National Institute of Mental Health's website, and feel free to contact me if you have questions. Thank you.